Good afternoon and welcome to HIT Policy Update, a complimentary webinar from healthsystemcio.com sponsored by OnBase by Highland. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the editor-in-chief of healthsystemcio.com. I'll be your moderator today. We encourage you to ask questions. You can type them in the Q&A box in the lower right-hand corner of your screen at any time and leave the default set to all panelists. We'll be taking those later in the program. You see the URL in front of you to get a hold of the deck. I will send it out in the chat box. There's also a shortened URL at the bottom of each slide. And we are recording today's event, so we'll have an archive available within 2 business days. You'll get an email when it's ready, and a separate registration is required. Just so you see how we're going to spend our time today, we're going to go about 45 minutes. First, we're going to hear from Dr. John Halamka, CIO at Beth Israel Deaconess Medical Center. Then we're going to hear from our sponsor, represented by Lorna Green, Senior Healthcare Informaticist with OnBase by Highland, and then we'll have our Q&A with Dr. Halamka. So without further delay, I'm going to turn it over to our good friend, Dr. John Halamka. Dr. Halamka, thanks for joining us.
And thank you so much, Anthony. And as I explained to Anthony, I've had a failure of my personal antivirus software. So if you find my voice a little scratchy and a few coughs, don't worry, the phone protects you from the 2014 flu. Anthony has done a great job in getting us together quarterly, and sometimes I reflect on the fact that, could there be enough novel policy happening every quarter to give you guys totally novel content? And once again, here it is a quarter later, and everything we're going to talk about today is completely different than the last time we got together. So today, we're going to cover some really important new developments at ONC. We'll go look at the 2015 planned milestones, all the dates for the activities of the Standards Committee and Policy Committee, when you're going to see government deliverables, when you can expect to see meaningful use stage 3. Yes, Anthony, I could comment on ICD-10, but I am just as much in the dark as probably everybody else as to whether that will really happen October 1, 2015, but I'll make a few comments there. We'll also look at the Federal Strategic Plan. It has 5 goals and 14 objectives. It synthesizes all of the requirements the federal agencies handed to ONC and puts it together into a nice framework. And that Federal HIT Strategic Plan underpins the Interoperability Roadmap. How do we get to a learning healthcare system over the next 10 years, and what are the various steps we need to take? What architectures are we likely to see? We'll comment just a bit on where Meaningful Use Stage 3 is going, where at least you see from ONC the published dates, but a few comments I have heard about what it might contain. And then we'll reflect on this private sector initiative you may have heard of called the Argonaut Project, and what it intends to achieve, why it's complementary to the federal government activities, and why it'll accelerate interoperability and innovation over the course of 2015 and beyond. So let's get started with looking at the milestones. So what you see is this month, in December, we have a variety of Policy and Standards Committee work groups. There's a new structure there to ensure that we're going to be very agile and responsive to help ONC as the activities of 2015 unfold. There's been a few recommendations made as to the nature of what an interoperability roadmap should contain, what are the 3, 6, and 10-year goals. And there has been recently published this Federal HIT Strategic Plan. I'll go through that in some detail in a moment. What we're going to see come February, and on February 10th, there is a joint meeting of all the Policy Committee and Standards Committee members to review the detailed report, could be hundreds of pages long, of this interoperability roadmap from ONC. We'll have an opportunity to offer feedback and comment. Our friends at ONC really don't want to be known as the organization of meaningful use. They really think of their mandate as much broader than meaningful use. You've probably seen that Congress is quite interested in interoperability. In fact, just the other day, Congress suggested to ONC we should actually start removing the certification from those EHRs and vendors that block interoperability. Now, I have to say that across all of our major vendors, I haven't experienced personally information blocking, but it does send an important signal to the industry that interoperability for clinical care coordination, care management, and population health even has the attention of our Congress. And speaking of Congress, the last session of Congress, of course, has just passed. We await the new Congress in January. But in the current session of Congress that just completed, there was not a revision of the ICD-10 October 1, 2015 due date, nor was there the hoped-for 90-day attestation for meaningful use stage 2 in 2015. So those will be taken up by the new Congress. I think many of us would argue the 90-day attestation period is absolutely required if we're going to see the uptake of the meaningful use stage 2 criteria, because as of the moment, we're still seeing about 4% of providers and some 20% of hospitals having crossed that finish line. So there's clearly gaps that need to be filled. So following that February 10th meeting, there'll be incorporation of all the comments on strategic plan and interoperability roadmap, and you'll see the production of some final documents. In parallel with those two important activities, there'll be the meaningful use stage 3 notice of proposed rulemaking, should come out in February. I have not seen it. I understand it has already been written. It is already in the Office of Management and Budget for review. What I hear is that it has been skinnied down, that it is less prescriptive, that what it has is a framework with a set of policy goals that offer some flexibility as to how those are achieved. And if that's the case, I certainly applaud that approach. I think many of us are feeling great meaningful use fatigue, felt that although stage 1 seemed very appropriate, stage 2 was aspirational and too prescriptive. It really defined workflows. And the principle of meaningful use should be to achieve policy outcomes, not to specifically require a given workflow or a vendor to implement very specific software features, because in some ways that slows innovation. And I think as we've seen, it certainly does not create great usability. Lots of clinicians and hospitals are fatigued by the process of meaningful use. Certainly, you could even ask, should there be a meaningful use stage 3? And I think as long as it's lightweight, it is based on policy goals, and there's flexibility, hopefully it will give us some general guidance on projects we would have wanted to do anyway, and that would be okay. So those are the major milestones. Now let's drill down on some of the details. As I mentioned, this federal healthcare IT strategic plan has to take a diverse set of inputs from all of our federal agencies and then distill them into a set of goals and objectives. So what you can see, and it's all very reasonable, that if meaningful use as a program had 3 stages, the federal health IT strategic plan itself has 3 stages, which get the data collected, EHRs, PHRs, care management systems, iPhones, whatever it is you need to get the data digital. That's good. And ensure that it is adopted across all the sectors of care, and hopefully, although we have not seen SNF, LTPAC, behavioral health incorporated in the meaningful use program, that there will be guidance and encouragement to get even those areas to be digital, and to make sure that across the continuum of your wellness that we have digital data for each aspect of your life that would help inform your care plan and ensure the care that gets delivered is per your preferences. Now, once we collect the data, of course, with patient consent, we'll want to share it broadly, and we'll go through some of the details of the objectives in a second. And if you assume that you collect and share, ideally, then you'd have use. Novel visualizations, feedback, reports that give doctors the ability to improve quality, safety, and efficiency, eliminate redundant testing and unnecessary treatment, and those sorts of things. And that's not just for clinical care, it's also for research and innovation, because this ecosystem of healthcare, of course, has important clinical care, teaching, and research missions. So, Anthony, I didn't actually include the details of every single objective, but just to give you a sense of what they are. Of those 5 goals, first one, expand adoption of healthcare IT, which is increasing the adoption of IT products, systems, and services, increase market confidence in the safety of those products, and ensure that there is a national communications infrastructure to support health, safety, and care delivery. And I don't think there's going to be a single national health information highway or anything like that, but having coordination and communication of technologies and policies that allow a modular network of networks is certainly a very reasonable approach to the collection of data, because there are so many places data will be collected from, as I mentioned, including your phone. Now, if we move on to share, that includes the advancing of the secure, interoperable health information sharing, and that includes enabling individuals, providers, public health entities to securely send, receive, and find. And that find means query response kinds of transactions from endpoints. We'll talk in a moment about what kind of standards and architectures you can expect for that query capability. It's not just sending a summary from place to place. It's actually querying data about a patient as you need it in many points of care. We want to identify, prioritize, and advance technical standards that support the secure, interoperable exchange of information, and of course, protect the privacy and security of health information, something that's increasingly hard to do. Pick up the paper any day and read about Sony, JP Morgan, Home Depot, and Target. We need to make sure that healthcare is not the next Sony. We also want to strengthen healthcare delivery as part of using the information that we exchange, and that's quality, access, experience of safe, timely, efficient, equitable, person-centered care, a move from the provider-centric world we have today of institutions and individuals to more person-centered care, wellness over episodic sickness, hopefully reducing cost, part of the triple aim, and increasing value. And that, of course, will have the better capacity to measure population health. We want to advance the health and well-being of individuals and communities, which means empowering individuals and families and caregivers for health management, and promote public health and healthy, resilient communities. In a time of Ebola, we should be able to do better detection of those with signs and symptoms of Ebola. As folks are familiar, in the Texas situation, we had a doctor who tried to do the right thing but didn't read the complete record. There wasn't a sharing of information across all the caregivers in this particular setting, and the patient was discharged home initially, despite knowledge of one of the care providers. The patient had recently had West African travel. And finally, this research, scientific knowledge, and innovation goal, we want to increase access and usability of high-quality electronic health information to all those stakeholders who need it. Might be de-identified aggregate data for the study of disease or pharmacovigilance. We want to accelerate the development and commercialization of innovative technologies and solutions. So I think you're going to see in both the healthcare IT strategic plan and in the interoperability roadmap, this idea that the private sector is going to play a very important role, and I think that's appropriate. Meaningful use was a catalyst. The federal government had a heavy hand with a lot of stimulus for stage 1 and stage 2, and in many ways it's now time to turn the incentives back to the private sector, because I don't think the barrier to health information exchange and use is so much technology. It's making sure we have the incentives to exchange the data. If we get paid for the care coordination and outcomes we achieve as opposed to the procedures we do, there will be more incentive to exchange information. And finally, the last objective under use is to invest, disseminate, and translate research on how healthcare IT can improve health and care delivery. If there is a novel IT innovation that happens in Massachusetts, well, it should find its way to Florida, not in 20 years, but more like 20 days. And how do we ensure that these innovations are rapidly disseminated? A lot of literature on the dissemination of innovation, and certainly we hope that through broad communication, through coordination, through the use of technical standards and policy frameworks, we're going to see the nation elevate its HIT capabilities across all stakeholders. So as you can see, these 5 goals, these 14 objectives, they're all actually pretty reasonable. And they're going to inform this interoperability framework that I've been discussing. So let's just go forward to the next slide. One of the things that will happen as you get to this interoperability framework is there are going to be some significant questions that are going to be raised, such as, If you have data from a Fitbit, and if you have data from your Medtronic pacemaker, how does a clinician know where the data came from and therefore make clinical decisions or trust that data and incorporate it into the record? We need to understand provenance. We need to understand data integrity. So, for example, the ONC has looked to the Standards Committee and its various work groups and has created 2 new task forces. One that is going to look at this provenance question. How by early 2015 do we recommend that devices, PHRs, and EHRs start to include metadata about who entered the data, how it was entered, how we can ensure it is unmodified, and therefore how is delivered to a new EHR, PHR application. It can be trusted and used for various purposes. And there may be elements of FDA regulation that fall into certain uses of that data. So this provenance and data integrity is really important. There's also a Standards Committee task force established on what's called standards harmonization. There's this federal project under ONC called the Standards and Interoperability Framework, or S&I Framework, and it has been around for several years. Is that the right way to harmonize standards? Should we turn it back to the SDOs, the standards development organizations in the private sector? What are our options for innovation and inventing the new standards we need for the devices that are emerging? So we will have a group that's multidisciplinary weigh in on how the country should best approach innovative standards and not just the repackaging of existing standards. So as I said, you'll see in February an interoperability roadmap. It layers on top of the Healthcare IT Strategic Plan. I would guess we'll focus on the same kind of interoperability ecosystem that Google, Facebook, and Apple have created of simple standards that will allow innovators to create modular applications that layer on top of our existent EHR infrastructure today. It's not a rip and replace. It's the hope that you can expand modularity and innovation and use standards like REST, the simple web standard that Google, Facebook, Amazon, Twitter, Apple all use to build the interoperability ecosystems they've created. There's a lot we can learn from the non-healthcare private sector. So more to come on that in February and in our next webinar. Now, I've mentioned this idea that there's going to be some emerging standards. And so let's talk about where I think that's going. Meaningful Use Stage 1 and 2 was about packaging data and sending that data from place to place. So you might imagine a discharge summary or a referral going from place to place, an admission notification or an emergency department discharge instruction sheet going back to a PCP. And that's all good for the kinds of one-time summary data that needs to go from place to place without any real-time urgency. It doesn't work so well if a patient shows up in an emergency department and you need to query the medication list, the last EKG, the problem list, the current labs. If we're going to eliminate the 15% of redundant lab tests and radiology tests done in this country, a summary that is sent episodically during an encounter, probably not so helpful. The ability to query all the sites of care where a patient has had diagnostic testing and in real time get a result is certainly going to help reduce redundant testing. So how do we do that? Over the last couple of years, Graham Grieve in Australia has worked on fast health interoperability resources, FHIR, under the auspices of HL7. The idea of FHIR is it, again, uses the Facebook, Amazon, Twitter kinds of approach. It uses simple JavaScript notation, not some arcane informatics standard, but simple JavaScript notation called JSON. It uses a RESTful protocol, very simple HTTPS, and it uses OAuth, the same kind of authentication mechanism that's used in social networking. It does not require big certificate repositories or public key kinds of infrastructure. It's the sort of thing a 16-year-old can write an app with over a weekend with minimum of healthcare domain expertise, not a PhD in informatics. FHIR has had an initial draft standard that's been published, and it was a good start, but it wasn't precisely aligned with a meaningful use program. So what's happened over the last month is that a number of private sector stakeholders that include Cerner, Epic, Meditech, Athena, McKesson, the Advisory Board, Mayo Clinic, Intermountain Healthcare, Beth Israel Deaconess, we've all come together and said we all believe we want to create this ecosystem of apps that enforces security, yes, but allows greater data liquidity in real time with queries from endpoints that could be EHRs, PHRs, aggregate repositories, or your phone. So we all agreed, every one of us, to contribute political will, laser-like focus, and dollars to HL7. So under the auspices of an open standards development organization that is ANSI credentialed, you will see an accelerated effort between now and May to issue validated standards that can be incorporated into EHRs to build what are called application program interfaces, or APIs, into Meditech and Athena and Epic and Cerner and McKesson and others, so that suddenly you don't have to struggle to get information in and out of these in real time. And it's really a public application program interface idea. It is not something that is going to be limited to that which the vendor allows you to do or has transaction fees associated with it. You, the user of the software, the doctor, the patient, the nurse, can decide what data is appropriate with consent to share. But then the fundamental technology, this API, would be available to those in the ecosystem who need it for read-write access to the data. So it's a very interesting idea. The two profiles we're working on for the May deliverable are, the first, a query response profile for the meaningful use data set, those 150 data elements that include the problem list, the medication list, laboratories, radiology, care team, care plan, immunizations. These are those structured data elements that comprise much of the medical record we need to deliver safe, effective, quality care. It's the sort of thing by which decision support can be offered. It's the sort of thing by which care coordination and care management can be achieved, and it's certainly very important to analytics and decision making. So that's the structured data piece. But we all know that about 50% of the medical record is unstructured. It's the free text note, the discharge summary. It could be the H&P. It could be a progress note. So as well, we will have a profile for the retrieval of discrete documents. You know, you ask for the discharge summary for a specific hospitalization and get that in real time. Those two profiles will be complemented by a set of security profiles that describe how to create a trust fabric in a community, how it is that doctors, hospitals, patients, payers, researchers can ensure that only those rightful individuals for the rightful purposes have access to this query response capability. So that will be fully published, and again, we'll use OAuth and OpenID. What will be interesting, and Anthony, I'm going to publish a blog in about an hour that shows you the charter for this activity and shows you who's involved and some of the basic guiding principles. One of the guiding principles, and I think you folks will find this really interesting, is that every one of the participants has agreed to open source 100% of the products of this activity. So that means Epic, Cerner, McKesson, Athena, the advisory board, all the providers, we're all going to open source everything we do. So you will have free, open standards for the query retrieve of data from all these various products, and that will be coming in May. So imagine this, that instead of having to wait for one of our EHR incumbents, and they're all good, they're all fine companies, to come up with three-dimensional holographic visualizations from wearable computing, it can actually be turned over to the entrepreneurial community in Silicon Valley or Kendall Square, because they will be able to query respond in real time to the data elements they need in the EHRs of the providers or patients or payers they are trying to support. So what I see is, just as the Apple Store has created this unbelievable ecosystem of innovation with some 20,000 new apps a month, we're going to, in effect, create an app store for health. and that it will be not just the incumbents, but it will be companies we've never heard of that are going to create the next layer of value-added applications that sit on top of our existing EHRs. And sure, of course, it is going to mean that the incumbent EHR companies will be able to exchange data more fluidly with each other, and that'll be great. But I really look forward to this edgy innovation that is going to be empowered by having the data liquidity of this FHIR application program interface that really does leverage a simple approach and gets simple right before we do complex. The Argonauts are not a new organization because a lot of this work was inspired by the Jason report that came out of MITRE Corporation and then was responded to by the Jason Task Force. Of course, in your Greek mythology, you remember that Jason and the Argonauts fought beasts, mythological, many of them, yes, and righted wrongs. So as all of these organizations in the private sector have come together, I've told them our mission is quite simple. We're simply a committee in a time-limited project, laser-like focused on delivering these two profiles and security to advance an interoperability ecosystem so we can slay the mythological beast of information blocking and right the wrongs of the past where there were silos of data. So that is what you're going to see between now and May. Some federal activities on strategic planning and a roadmap, but some private sector activities now fully funded and fully organized. And an hour from now, you'll see the charter and all the details on how it will work, when the products will be delivered, who will be involved, and the kinds of participation that can be had from any organization. It's a very open approach. So with that, Anthony, of course, wanted to leave time for Lorna, as well as open it up to questions at the end. So let me turn it back to you.
All right. Thank you so much, Dr. Halamka. Looking forward to our Q&A portion. And as you mentioned, now we're going to hear from Lorna Green, Senior Healthcare Informaticist with OnBase by Hyland. Lorna?
Thank you so much for letting me be here today, Anthony. And thank you, Dr. Halamka, for another good update. I know myself, I'm always reading, and this is so interesting to me to hear you pulling some of this together. I'm sorry, Anthony. Oh, I did just make it go forward. This is a slide that I've used before in my other introductions to give you an overview of Hyland and OnBase by Hyland. I'm sorry, I'm tongue-tied today. OnBase is an enterprise content management solution. We are not an EMR. We're complementary to your EMR, and that's one thing I always want to make sure that you understand is that we bring the data together into one place, and we right now are bringing documents and lab work and EKGs and that type thing. But in the very near future, we're going to also be bringing DICOM images and other medical imaging into one repository, one viewer. And I was really excited to hear what Dr. Halamka was talking about with sharing of data, because we have developed a product called OnBase Anywhere. And if you're an Epic site, it's similar to the project that you have with them, where you can actually go out in between OnBase sites that are signed up. You can query, as Dr. Halamka talked about, looking for specific data on patients. And so we're real excited to hear that this is something that will be important as we're coming into the next year with healthcare IT. What I wanted to focus on today is another capability that OnBase has, and that's our mobile eCapture. We have several platforms for doing this, but we have the ability for you to use a device, whether it's a Windows device or an iOS, and enter in data through these devices. It's patient-friendly. We make customized form packets. We give the ability for there to be electronic signatures on these forms. And a benefit of this is it helps you prevent having incomplete forms. And then the second benefit of that is that it gives timely and intuitive access to your clinicians. Once those documents are signed, they go immediately into OnBase, and then anyone who has the correct access can view and see them. As I've shown y'all here before, we have OnBase has industry recognition. We are exclusively endorsed by American Hospital Association, consistently ranked high in class, and we're a leader in the Gartner's Magic Quadrant. If you have any questions or would like to know more about any of the things I've mentioned here today, please feel free to contact me or go onto the website and send in an inquiry. Thank you, Anthony.
Well, very good, and thank you very much, Lorna, and your support of this event. All right, great, Dr. Halamka, time for questions. Some loaded, some not.
Can't wait.
Let's start. You mentioned the first profile MU query response has a May target. Does the unstructured profile have the same time frame?
It does indeed. And so what we've decided to do is break the project into two chunks where the fire work under HL7 will deliver both profiles in the May timeframe. We'll, of course, leverage work that's been done by the data access framework in the SNI framework of ONC. We'll leverage work that's been done in the past by IHE. We're even leveraging work and thinking forward to how some of the existing collaborations like the health services activities of Stan Huff, organized through Intermountain, can be used. And all that comes out in May. The security piece is being done with a slightly different time frame. We have a group that's all coming together to review all the existent OAuth and OpenID activities. We wanted to have a multidisciplinary group of security experts working on that. And then we hope that the HL7 folks will include the result of that investigation into the FHIR ballots and profiles. So, you know, you're going to see all the HL7 FHIR stuff in May, hopefully security stuff coming out in the summer time frame, and then, you know, a variety of HL7 balloting processes. But by May, you certainly have the document profile.
Great. A person had mentioned that they wished Allscripts was participating. Are they not participating in the open source initiative you mentioned?
So there are three kinds of participants in the Argonaut project, if you call it that. Sponsors, those who will do pilots, and those who just want to stay part of the community. And I didn't mention the word Allscripts just because they weren't one of the initial sponsors, but actually Allscripts is very interested, and I think they will fall into the pilot category. So I think SureScripts, Allscripts, I mean, there's a couple of organizations, that GE, that have expressed interests in doing pilots. So don't worry, I mean, this is going to be a very broad industry initiative.
We got a yay from the person, I guess the Allscripts customer. Question, the federal budget for incentives was $29 billion. They've gone through over $25 billion so far. We'll probably see it gone by mid next year. What do you think will happen when the money runs out? What will happen to the behavioral and other initiatives when, I'm assuming it's supposed to finish, no money is left?
So my hope is that, as I said, that federal government was foundational and a great catalyst and took us from 20% adoption to 80% adoption of healthcare IT in this country. But the federal government is going to run out of dollars, and therefore it's up to the private sector. And so I would think that what would happen is that the meaningful use program will come to a graceful end, and that's okay. I actually hope that the penalties are eliminated, because I think, you know, it's a little bit unfair to say, here are some really hard aspirational goals. Oh, you didn't meet them? Shame on you. Here's a penalty. So let's spend the stimulus until it's done, getting all of those stakeholders, including behavioral health and long-term care, all aligned to the extent we can. If it's not Medicare stimulus, maybe it's Medicaid programs, grants, or other things. And then once that's done, let the private sector and let new funding models like pay for outcomes incent folks to continue their use of healthcare IT. It's just time, I think, for that private sector and the economics of aligning stakeholders to shift from stimulus to now, how do I save money? How do I be more successful using healthcare IT?
Very good. Has Jason and the Argonauts killed Commonwealth?
Oh, what a fun question that is. So let me explain what Commonwealth is and isn't, right? So it's not a competitive thing to the Argonauts. Commonwealth is more interested in providing a registry of patients. And let me explain what that means. Suppose, since I don't have a national healthcare identifier, I go to Beth Israel Deaconess, a doctor's office in Chestnut Hill, an emergency department in Needham, oh, and I trip and fall while flying to California or whatever. You know, how do you know where my records are? I could tell you, and that's okay, but if I'm not capable of telling you, probably you need some kind of index. So Commonwealth is interested in creating the standards by which, with patient consent, an index can be maintained so the standards I talked about, like FHIR and RESTful approaches, can be used to figure out where your records are and then query them wherever they may be. So think of the Commonwealth as completely complementary to these other efforts, and it may be helpful in some regions and not in others. Massachusetts has already created a registry of patients we call the Relationship Locator Service. So probably in Massachusetts, we wouldn't need that particular infrastructure. But most states don't have one, so that's okay.
All right. Here's a loaded question, obvious, but, you know, see where you want to go with it. How likely is it that the proposed HL7 FHIR interface will be easy enough to use and manage that vendors can reduce their overhead enough to be able and willing to waive their transaction fees for getting data into and out of their EHRs?
Well, that's a great question. So this Argonaut committee, and we met for 2 hours yesterday, is unbelievably focused on simplicity. Everyone who wants to expand the use case, add complexity, we're just ruthless. No. You know, it's 150 data elements, each of which has a vocabulary that's available from the National Library of Medicine for free, and that's what we're doing. No extra complexity here. So on the one hand, yes, I think it'll be very simple. I think it's a good foundation. I also hope that vendors receive pressure from their users that interoperability isn't a business model. I can understand something like a subscription to a component. You know, you pay a few $1,000s a year to have a component that is able to do all this great query response stuff. But I think transaction fees are a disincentive to commerce. They create friction. So I will hope that all the vendors in America eliminate the concept of transaction fees for interoperability.
Very good. I'm not sure if this question will make sense to you or not, but let's go with it. Has there been any discussion of the relation of OAuth to NIST and the U.S. government multi-agency information security automation program? And you may see that question in the Q&A box on the bottom right-hand corner of your screen if you want to see the exact wording.
Right, and so Dixie Baker, who has led the Privacy and Security Work Group of the Standards Committee, has actually been keeping in close touch with all these various federal efforts. The notion of the National Infrastructure for Trust in Cyberspace, the NSTIC program. And so to us, this OAuth approach obviously tries to take into account the various authentication and authorization problems we are trying to solve, and you use OAuth where it's appropriate. Now, in protecting nuclear secrets, the federal government may have slightly more detailed requirements, and it may be two-factor, and it may be something that you have and something that you know. So our intent is to align this OAuth OpenID effort with work that has been done in implementation before it, to use it where that level of security and assurance is appropriate, but by no means does that replace other efforts like NSTIC, where you might need more rigorous authentication for protection of nuclear secrets or something like that. So think of it as complementary, not competitive.
Very good. Well, let's talk a little bit about the order in which things have happened with meaningful use. You know, as you've had in one of those slides, it was get the systems out there, and sort of interoperability, a focus on that has come second. In your mind, if you could have done it over, would you have done things the other way around? Are we trying to fix some things that could have been done better if they'd been done the other way around?
One of the things we've been really careful of in this Argonaut project is to use what we call the Dixie Baker Standards Maturity Scale. And that is Dixie led a committee with Dave McCauley, Arian Malik, and some others to come up with objective criteria for what defines a standard that's good enough for broad use. It is sometimes, the only way you can get something out there is to try it, see how it works, and revise it. So I'm a great believer in plan, do, study, act, and those kinds of approaches. However, to come up with a national mandate for required use of software or technologies that aren't quite ready for prime time is inappropriate. So with the Argonaut Committee, here's what we've said. We will, with ONC, telegraph that this query response activity is the future and it's coming, but it will not be included in any regulatory requirements until it has been proven to be safe and effective through the wide-scale use of pilots that have had the opportunity to test and refine it. So I agree with the spirit of the question. Invent, test, refine, and only then require.
I think just maybe as a final question, but what would your advice be? What's your request to healthcare IT professionals in hospitals on the line today regarding some of the projects that you talked about and you're involved in? What would you want them to say to their software vendors, or what would you want them to encourage their vendors to do or participate in or be aware of?
Sure. The future, as outlined in the Federal Strategic Plan and in the Interoperability Roadmap, is going to be, I wouldn't call it best of breed, because we all know best of breed is a bit problematic. But how about this? Best of suite. You've decided your whole inpatient and outpatient facility will run on one core EHR. That's good. But then when it comes to, I want unique decision support, I want something that is going to help me visualize my performance, I want a care management medical record, I want some unique patient family engagement tools, those are probably going to be third-party products. So what you want to encourage is that Apple sells more iPhones because there's a whole lot more software than just what Apple makes. I'm convinced that EHR companies will sell a whole lot more of their products if they open up their platforms so that folks will have the opportunity to add third-party modules on top of those platforms. That's going to add value. So embrace this FHIR idea. Embrace the modularity concept. It is absolutely not competitive. It's going to create an ecosystem that is going to result in better sales of the core vendor products.
Well, that's excellent, and I think that's where we're going to wind it up today. Again, I want to thank Dr. Halamka for joining us and continuing to do these. I think they're very useful for the industry, and we certainly appreciate him doing them with us. I want to thank OnBase by Highland and Lorna for continuing to sponsor these events. As I mentioned, you'll receive an email when our archive recording is ready, and a separate registration is required. For those with the CHIME CIO certification, if you've asked us to report to CHIME your attendance, we will. If not, please do that yourself. Attending our webinars gets you 1 CEU for each event. Questions, comments, please contact me. Always looking to hear suggestions for improvements. And you can go to our website to view our upcoming schedule and see the last 12 months of archived events. So once again, I want to thank Dr. Halamka and Lorna and our attendees, and everybody have a wonderful day. Thank you.
Thank you.